Hi, good evening. My name is Mandeep Singh, and I'm the moderator for this acute coronary syndrome webinar coming to you live from Mayo Clinic, Rochester. I'm the director for the acute coronary syndrome program at the Mayo Foundation. It is my distinct pleasure and honor to have Dr. Abhiram Prasad. Abhi has been with me, my colleague, my friend. We are in the interventional lab together for the last 25 plus years. And he has established his name in the realm of coronary physiology, endothelial dysfunction, but more so in the management diagnosis of Takotsubo cardiomyopathy, on which he will speak today. Dr. Prasad did his early training in London before moving to Mayo Clinic, where he trained, and then joined as a staff for the last 25 some years. And he has excelled in the interventional lab, doing complex PCIs, including chronic total occlusions. But today he will talk on a subject that is very dear to his heart, on Takotsubo cardiomyopathy, its diagnosis and management. Dr. Prasad, it is really an honor and pleasure to have you.
Thank you, Dr. Singh. It's a pleasure to be here. Hello, everyone. And thank you, Mandeep. It's a real pleasure. You may be wondering why an interventional cardiologist who does CTOs would be interested in Takotsubo cardiomyopathy. And really, I see this as a privilege that I've been involved in this condition. It's not often in one's career that you get a chance to really come across or stumble on a new entity, or at least what we think is a new entity. So let me walk you through what I've discovered, and I'm sure many of you know much of this, but hopefully there'll be some new data here. So these are the learning objectives. We'll talk about the typical clinical presentations, diagnostic criteria. We'll try to understand the pathophysiology the best as we do currently, and we'll talk about management and prognosis. And the presentation is divided into these 5 sections, and we'll go through them one by one. So, while we think of this condition being something of a relative new entity in the world of medicine, it's always the case that if you look back, people have really seen this condition before and called it by different names. So here's Walter Cannon. He was an eminent professor and chairman of the Department of Physiology at Harvard in the 1940s. And he is most famous for having coined the term fight or flight response that we all are familiar with. But he also published a paper called The Voodoo Death. And you'll be familiar with the idea of the voodoo doctors in Africa who can incite fear and even death in people. And he went ahead and actually said that voodoo death was probably related to either as an emotional stress, which was obvious, or repressed terror. Now, you could imagine that this was probably Takotsubo cardiomyopathy. It just wasn't called that. And I think this happens in each generation. We discover things that people have known before. And that's really my story. So my interest in Takotsubo started when I was a fellow here at Mayo Clinic. I'd spent many years in London, so I was familiar with acute coronary syndromes. And so having done that for many years, it was obvious when you see something new that something isn't fitting. And that was the case one day when a woman, middle-aged woman, presented with what appeared to be an acute myocardial infarction, but the coronaries were normal. But she had extensive regional wall motion abnormalities. And I went around asking some of the senior colleagues, and they said, well, it looks like stunned myocardium, maybe it's spasms, and so on. And it really didn't make sense to me. So I did some literature searching, and just by chance that year, there was this publication called Transient Left Ventricular Apical Ballooning Syndrome, a novel syndrome from Japan, where they published a series of 88 patients. And when I read this paper, all women, it became immediately evident that the patient that we had in the CCU was exactly this type of patient that they called apical ballooning syndrome. And this paper is now a landmark paper published, cited well over 1,000 times. And so we said, how about looking through our database and see whether similar patients have presented before at Mayo Clinic? And sure enough, if we looked back 1 decade and came across 18 patients in the cath lab database who were identical to the patient that I'd seen in the CCU. And when I looked at their chart as to what the diagnosis was in the past, these were typically labeled as either acute myocardial infarction with embolus, spasm, and all of those sort of diagnoses that we're familiar with. And we published this series in 2004. And I'll just show you the key findings from that in a moment. But really, what we've gone from what was 2 decades ago to now commonly cited in the lay press, often known as the broken heart syndrome. And I was just Googling recently as I was preparing for this presentation, and there was an article on Lisa Presley, somebody thinking that maybe her death was related to the broken heart syndrome. So really, this diagnosis has entered the sort of popular press. One that I love and I like showing is this one from the newspapers. Woman mistakes wasabi for avocado and develops broken heart syndrome. This was a real story of a middle-aged woman who was attending a wedding and took a spoonful of wasabi, and that prompted her to end up in the hospital. Fortunately, she did well. So the triggers for this condition can be many, but the final outcome we'll talk about is pretty similar in all these patients. So the nomenclature has evolved. As I mentioned, we used to call it apical ballooning syndrome. Many of us still do. The Japanese also came up with the Takotsubo, which is the octopus trapping pot that looks like the ballooned ventricle. There's some debate as to whether it should be called a cardiomyopathy or a syndrome. I don't think it matters too much. And these other names that have been given to this condition, they are all talking about the same condition. So let's move on to some typical clinical characteristics. It's important to be familiar. I think the pendulum has swung to the point where people think they're very familiar with it and end up overdiagnosing this condition. So here's a 78-year-old woman who presented with a 2-hour history of severe chest pain while she was visiting her husband, who was also in the hospital. And her examination was normal. The troponin T was only mildly elevated at 202. With our current 5th-generation assays, a large infarct would be in the thousands. And this is the first of many learning points that I'd like to pass on to you, is that typically in Takotsubo, troponin levels are not very high. They're at the levels of a small non-SDMI. If you have a patient with very high troponin levels, think again about the diagnosis. This is her ECG. You see some subtle SD elevation and loss of R-wave progression. So there was concern that this patient may have a STEMI. She was rushed to the cath lab. There was mild to moderate left and right system coronary disease, but no culprit lesion. But the left ventriculogram showed this classic pattern of apical ballooning, so akinesis of the mid and apical segments. The LVEDP was elevated at 30, and that's one of the reasons that many of these patients develop heart failure, because not only do they have systolic dysfunction, but they have acute diastolic dysfunction, sometimes more so than you see in myocardial infarctions. So this was her ECG the following day. You see the classic evolutionary changes of T-wave inversion, quite deep, which extends beyond any single coronary territory. You start seeing T-wave inversion in the limb leads too. This is classical of Takotsubo. And QT interval prolongation. This is also very typical, but doesn't have to be always present. So when we looked at all our initial series from our registry, we came across these few findings that I think cannot be argued against. This condition is almost a mimic, if not a typical, acute myocardial infarction presentation in most patients. It accounts for 1 to 2% of all acute myocardial infarctions. No matter which registry across the world, the findings have always been the same. Typically seen in postmenopausal women, but can occur in men. Chest pain and dyspnea are by far the commonest symptoms. 2/3 of patients will have a trigger, but importantly, 1/3 will not. 30 to 40% develop heart failure. Shock can occur. And those who survive, complete recovery of ejection fraction is the rule. So if you have a patient who does not recover their ejection fraction, rethink the diagnosis. So based on our initial publications and experience, we were approached by colleagues from Switzerland who wanted to set up an international database, the so-called INTERTAC registry that you may be familiar with. This was 26 centers, 9 countries, and we were one of the 2 or 3 centers in the United States. This was the landmark paper they published a few years later with just over 1,750 patients, and this has now become the most cited paper on this topic. Let me show you some data from this paper. They showed the age distribution. I think we had recognized this, but they had just done a very nice job of showing this in a figure. In women, the peak decade is in their 70s, whereas in men, shown here in dark blue, the peak decade is in their 60s. So men tend to be a little younger when they develop it. And in this series, and in most series, a larger series at least, around 10% of patients are men. The other thing I want to point out to you is all ages can develop Takotsubo. So look here, they had patients as young as in their teens, and there have been case reports of Takotsubo occurring in babies. So certainly doesn't rule it out if somebody is particularly young. It's a good time to talk about Takotsubo because during COVID, there's been a marked increase in the incidence. Typically, there is a constant rate of around 1 to 2% of all acute myocardial infarctions being Takotsubo ultimately as a diagnosis. But during the first few months of the COVID-19 pandemic, there was almost a fourfold increase in the incidence. This is data from the Cleveland Clinic. What else did they show in this New England Journal paper? Well, they did a nice job of showing the triggers. They reported around 38% were physical triggers. I like to think of this as a rule of 1/3. 1/3 are physical triggers, 1/3 emotional, 1/3 do not have a trigger. Now, depending on your practice, this split can change. If you work in a tertiary care center, you'll see more physical triggers. If you work in a lower intensity environment, you may see more patients with emotional triggers, largely because the physical triggers are patients having major surgeries or patients on cancer and bone marrow transplant units and so on. If you break down the emotional triggers, this could be almost anything, but sudden sort of anger, fear, conflict, loss of a job, financial stress have all been shown to be the kind of triggers that you see. It's also important to realize that about 5% of cases occur with happy emotional responses, so-called happy heart syndrome. For example, birth of a grandson or somebody in the family making some achievement. All of these things have been associated with the Takotsubo syndrome. In terms of physical triggers, by far the commonest trigger, I would say, is COPD exacerbation. This has been repeatedly shown, perhaps because of the use of bronchodilators and the sympathetic response to the COPD. In terms of physical stresses that are non-medical, I would say orthopedic fractures and surgeries are by far the commonest, but other things like malignancies and virtually anything you can think of, sepsis on ICUs, can be triggers. People who spend a lot of time thinking about this have coined terms of primary for emotional triggers and secondary for physical. I don't think this has entered common sort of language when we talk about this condition, but certainly you may see these terminologies of primary and secondary, and you'll be familiar with that being emotional versus physical triggers. What about the ECG? Here again, I'd like to talk about the rule of 1/3. 1/3 have ST elevation at presentation, 1/3 have deep T-wave inversion, and 1/3 have either a normal ECG or very subtle non-specific changes. So the rule of 1/3 applies to the electrocardiogram. And if you wondered what these ECG patterns do in terms of correlation with outcomes, the short answer is nothing. The outcomes are identical no matter what ECG presentation you may have, although you may have hypothesized that those with ST elevation, greater perhaps myocardial injury at the beginning, would have worse outcomes, but certainly didn't pan out in our study. Here's a summary slide just showing the similarity between acute myocardial infarction and Takotsubo. The symptoms are the same. The biomarker pattern is the same. But I did point out to you earlier, and I'd like to say it again, the level of troponin elevation in Takotsubo is much lower than STEMIs and is like a small non-STEMI. If you still are using CKMBs, it may be the case that rarely CKMB may be normal, but with troponins, they are always elevated. So if you have a patient with normal troponins, that patient does not have Takotsubo. BNP levels are always elevated, and in fact, they are higher than seen in STEMI, interestingly. And then the wall motion abnormalities we'll show a little bit more about in a moment. The complications in terms of qualitatively are similar to acute myocardial infarction, but heart failure is very common. Shock occurs in about 5% of patients. Thrombus, important to look for, in 1% of patients in strokes can occur as a complication of that. Arrest and lethal arrhythmias are more common than we realized originally. About 5% of patients will have it. And death, 3 to 5%. Again, this number is not a hard and fast rule. These complication rates will depend on your practice and the proportion of patients with physical triggers, and we'll come back to that. You may have heard of the variants of Takotsubo. We've shown you an apical ballooning variant. There's the so-called midventricular variant shown here, where the apex is preserved and the base function is preserved, but the mid segments are akinetic. Nothing else in our field looks quite like this. It's really quite fascinating, and you can see why, despite my keen interest in interventional cardiology, I pursued my research interests in this topic, because I think that if we unlock the secrets of this condition, we will make important observations about many other aspects of myocardial function. Here's another variant. This is the so-called inverted Takotsubo, where the apex is preserved but the base is akinetic. We think that this variant occurs more often in younger patients or in men. This is a 40-year-old woman who came in with a methamphetamine overdose. Another thing I'd like to point out is the fact that this is in fact a biventricular cardiomyopathy in a lot of patients. This is a RV gram. When we first showed this, the akinetic right ventricle apex here with a hyperdynamic base. And these patients who have biventricular Takotsubo tend to be sicker, they have more heart failure, lower ejection fractions, and longer hospitalizations. They're just a sicker group of patients, so perhaps they had a greater catecholamine stress. So how do we diagnose or differentially diagnose this from an acute myocardial infarction? No easy single test for it. I think we have to use our clinical acumen, the combination of the ECG and imaging findings. So when we initially came across the condition, we said, well, how about the ECG? Could that differentiate the two conditions? Short answer is no. In light blue here, we have Takotsubo, dark blue STEMI patients. And what you see is STEMI patients tend to have more widespread precordial changes. These were anterior STEMIs. And greater amount of ST segment depression, but really the patterns were very similar. And others have looked at this in many ways and tried to quantify ECG ST segment changes and other variants, and really have not been able to find a criteria that can differentiate the two conditions. More recently, the group, as I mentioned earlier, this international registry, the INTERTAC registry, came out with a scoring system using 7 variables and suggested that a score of less than 70 is low likelihood of Takotsubo, score of greater than 70 high, but really, again, it does not have the sensitivity to differentiate these two conditions. So interesting, but not useful in clinical practice. So how do we diagnose? Well, basically using diagnostic criteria. We came up with this many years ago and revised it slightly in 2008, the so-called Mayo Clinic diagnostic criteria, where we said that the regional wall motion abnormalities must extend beyond a typical single vessel distribution, although recognizing that rarely there are variants where the regional wall motion abnormality is very limited to a single distribution. But most of the time, the regional wall motion abnormalities will be very widespread. They should, of course, be absence of obstructive coronary artery disease, but mild disease is very common, and in fact, rarely obstructive coronary artery disease may coexist where an acute myocardial infarction is a trigger for Takotsubo cardiomyopathy. The first time we saw this, we didn't really make much of it, but then we saw reports all around the world, and I think this is indeed a real entity where a ACS is a trigger for Takotsubo. So exceptions to each of these criteria. Again, rule number 3 is either an ECG abnormality or with contemporary troponin assays that should always be elevated, and most patients should have an ECG abnormality. Exclude myocarditis for obvious reasons. We had also excluded pheochromocytomas, largely because pheochromocytoma is such a rare and unique condition, and the cardiomyopathy associated with it is very rare, that we typically wanted to exclude that and remind people to look for it and exclude it. But others have suggested that maybe pheochromocytoma cardiomyopathy is the same as Takotsubo. And so the INTERDAC registry folks came up with a much more detailed criteria. I'm not going to go through all of this, but you can see the areas that I've highlighted. They've tried to be much more comprehensive, acknowledge that right ventricular involvement may be present, triggers, neurological disorders, and so on, and just tried to really be more comprehensive. But again, none of these criteria have been really validated in large cohorts, so I think they're just sort of flags for you to use as pointers. What is very helpful is the cardiac MRI. Whenever there is doubt in your mind about the differential between acute myocardial infarction, myocarditis, and Takotsubo, do a cardiac MRI because you will find it to be very helpful. So it shows the regional wall motion abnormalities beautifully. It shows you biventricular involvement very beautifully, complications like mitral regurgitation, as you see here, the presence of thrombus, if it was there, and the presence of edema, which is a hallmark. With T2 imaging, you can see edema in the myocardium in the distribution of the regional wall motion abnormalities. So most radiologists will be able to tell you whether they think this is Takotsubo or not, or myocarditis, or if there's late gadolinium enhancement of myocardial infarction. So I would say that cardiac MRI is highly recommended. Do it as a rule if it's possible in your practice, but whenever there is a doubt, use this as your differential diagnosis tool. So here's my construct. If you have a patient with a very fulminant clinical presentation that's suggestive of myocarditis, go straight to a CMR. But in reality, most patients either present to us either through the cath lab with concerns for an ACS, and if that's the case, if there's coronary disease, you've got your diagnosis of ACS, but if there isn't, consider the diagnosis of Takotsubo and do a CMR. On the other hand, many patients who are in the hospital present via the echo lab, where they're sick in the hospital on ICUs, get an echo, and it shows something called apical, that they think it's apical ballooning. I would caution you not to jump to conclusion, but remember that the diagnostic criteria ask you to rule out coronary artery disease, and that means getting an angiogram. If the patient is too sick for it, consider a CT coronary angiogram or a deferred coronary imaging when they've recovered, recognizing that some patients may never have the opportunity to have their coronaries imaged. In those cases, I would hedge your bets and call it probable or possible Takotsubo, but don't be too sure, because we know that LAD infarcts can really look like Takotsubo on an echo if the imaging has not been done very carefully. And then remember to do follow-up imaging in 4 to 8 weeks or so to make sure there's been full recovery. If you have a patient where there has not been full recovery of regional wall motion abnormalities, reconsider your diagnosis. It is true that there have been case reports of very subtle residual regional wall motion abnormalities, but that's pretty uncommon in our experience. So let's move on to pathophysiology, having talked about the clinical presentation. What do we know so far? Well, this is the construct that I carry in my mind. We've shown that there is no doubt that triggers play a role. So if triggers play a role, then catecholamine surge must be part of that. And I think this is widely accepted, and I'll show you why, the kind of circumstantial evidence that supports this. But clearly, catecholamines cannot be the whole story. Otherwise, all of us would develop Takotsubo, right? Because we, at some time in our life, have the kind of physical or emotional triggers that I have talked about. So what is that individual susceptibility? I think this is really a fascinating area that needs further explanation. But what do we know so far? Well, we know gender, women are affected, and postmenopausal status. But if that was the only susceptibility, then half the population in the world would develop Takotsubo. But clearly most women do not. So what other susceptibilities are there? Well, a few years ago, we looked through our Ulster County data and showed that the prevalence of anxiety and depression was extremely high in these patients. So I think pre-existing anxiety and depression is a major substrate. The next thing, more recently on brain imaging, has supported the same idea that there are changes within the brain of these patients that pre-exist the occurrence of Takotsubo. There's a nice paper on this. In this paper, they showed that there was chronically increased amygdala activity. Another thing that I think few would now argue is that there seems to be a high prevalence of underlying microvascular dysfunction as a susceptibility component. And I'll talk about that in a moment. You would wonder whether there's a genetic association, and we were pretty excited many years ago when we found a mother-daughter pair that we published as a case report. But in fact, when we did gene-wide analyses, we really never found a gene that could support that. And really, we haven't found too many such familial clustering. So I think genetics plays a small role, if any. And then this condition then presents with this classical myocardial stunning, which is likely from calcium overload, but other features that are seen is oxidative stress within the myocytes. Abnormal metabolism is seen on PET imaging on the glucose and fatty acid side. Inflammation is now recognized as a major part, but no surprise given that there is some myocardial injury. And edema, as I said, is a very classic feature of Takotsubo. Microvascular dysfunction is acutely present, but as I said earlier, we think that it's probably chronically present in these patients. And then a few patients have spasm. In the early days, it was thought that my epicardial spasm and a multivessel distribution was actually the pathology, but we've now recognized that it's probably a bystander, but not the actual cause for the syndrome. So what supports the catecholamine hypothesis? Well, the observation that triggers play a part, stressful triggers, but also that pheochromocytoma is associated with a similar cardiomyopathy. Some centers have reported elevated blood levels of catecholamines, but when we tried looking for this using 24-hour catecholamine collections and blood levels, we could not replicate that work. There are reports showing that accidental administration of large doses of catecholamines results in Takotsubo. There are case reports of stress-induced, for example, dobutamine stress tests causing Takotsubo. So I think there's a whole body of evidence supporting the catecholamine hypothesis, and I think that forms the core of the pathophysiology. In terms of the microcirculation, which I think is the other piece of this that I think is very well established, this was our initial paper in 42 patients where we found using myocardial blush. Again, me being a cath lab person, that's where much of my data came from. We looked at myocardial TIMI blush scores and showed that the majority of patients had abnormal blush score. Remember, 0 being very abnormal, a totally occluded microcirculation, 3 being normal. And we showed that there was a nice correlation between troponin levels and the level of microvascular dysfunction. And then we said, well, okay, so there is acute microvascular dysfunction, but what happens chronically when these patients recover? And so we brought a bunch of these patients back to the cath lab and infused acetylcholine into their coronary arteries. This is what should happen in a normal person, where the blood flow should increase by about 100%, so doubling of flow with acetylcholine. So what happened in our Takotsubo patients? Well, this is what happened. Virtually no increase in flow. Really quite a dramatic finding supporting the idea that there is chronic microvascular dysfunction in these patients, and others have replicated this data too. Another interesting area of growth for pathophysiological investigation is brain imaging. I showed you some data earlier, or at least talked about it. And here's a case series of 3 patients from Japan where they looked at acute brain SPECT imaging and showed that there were abnormalities in blood flow in certain areas associated with the stress response, such as the brainstem, hippocampus, basal ganglia, and neocortex. And these then recover if the brain is imaged later once the Takotsubo has recovered. And this work has been somewhat reproducible as well. So we'll stop there on the pathophysiology, but I'd be very happy to take questions later on that. And let's move on to the final part of this presentation on treatment and prognosis. I think it's fair to say that there is no randomized data on this, and so much of what I'm telling you is really consensus or expert opinion. So what do? We avoid beta-2 agonists and catecholamines because we think that's the central feature of this condition. And more importantly, and perhaps we don't think about this enough, is avoid QT interval prolonging agents because we know that ventricular arrhythmias can occur. How long should you monitor these patients? I would suggest somewhere between 24 to 48 hours. Again, those who present with the high-risk features, and we'll talk about what those are in a moment, should be monitored longer than those who perhaps present with a simple emotional trigger. If there are no complications, then initiate ACE inhibitors and beta blockers as if you are treating any other cardiomyopathy, because remember, at this point, you cannot be sure that this is Takotsubo, no matter how typical the case appears. And so it's important to treat them as you would according to guideline therapy for acute LV dysfunction. In terms of acute heart failure, we've talked about the fact that 30 to 40%, this is the most common complication. Get this, and so manage it as you would with any other patient. Some patients develop hypotension. It's important to rule out LVOT obstruction if there's significant hypotension. About 10 to 20% of patients will have it, and the management here would be very different to patients who just have simple pump failure. And here you would treat them as if you have a patient with LVOT obstruction with hypertrophic cardiomyopathy. The same rules apply. If there is cardiogenic shock, we recommend the use of mechanical support devices over inotropes, again, for obvious reasons. You do not want to give more catecholamines in a situation where you think there is catecholamine toxicity. Once the patients have recovered and are ready for discharge, we typically recommend, again, heart failure therapies with beta blocker and ACE inhibitors until you have demonstrated that LV function has recovered and indeed your diagnosis was correct. And it's possible that these agents may, in fact, aid recovery, although there is no evidence to support that at this time. A more important and less often thought about issue is the management of the associated anxiety and depression that predates stress management, and if needed in severe cases, psych consults should be thought about. We think that this may play a role in preventing recurrences, but again, remains to be established. What about beta blockers? This is a question I often get. Can that prevent recurrence? The short answer is we don't know. Data so far has been very mixed on this for various registries, but we continue to administer beta blockers in the hope that it does have some catecholamine blunting effect and reduce recurrences. So what are the high-risk features that predict poor in-hospital mortality and complications? Older age, male gender, the presence of a physical trigger, and a lower initial ejection fraction, anything below 40%, certainly below 35%. This is your high-risk cohort. Men and physical triggers and neurological triggers and just a generally sick population are the other sort of softer risk factors, I would say, for worse outcomes. So here's some data about outcomes in the long term. This is 265 patients from a Mayo Clinic registry, published not too long ago, 6-year follow-up. And what we showed here was in the solid bar are the patients with Takotsubo, and in the lighter bar line is the age and gender matched population. And you can see that Takotsubo patients seem to do a little worse than age-matched cohort. But the story isn't simply that Takotsubo somehow is a malignant condition, but rather what else goes along with it. So when we looked at the presence of cancer, we saw these curves split a lot. Patients who didn't have cancer did much better than those who had a history of cancer, obviously goes without saying. And then when we looked at this data according to the type of trigger, we found that those who had a physical trigger did much worse than those who'd had emotional trigger or no trigger. So it seems that the worst outcomes that have been reported of late are probably related to the concomitant illnesses that these patients have. But there is no doubt that there is a small but present risk of Takotsubo-related direct mortality too. What about recurrences? 2%. Every registry shows it the same. This is a number you can commit to your memory. 2% per year. More common in those who have psychiatric illnesses or neurological disorders. And another interesting thing that you may not be familiar with is that about 1/3 of these patients continue to have chest pain. And when we initially saw this in our registry, we didn't make much of it, but others have reported the same thing. And we think this is because they have this sort of microvascular dysfunction as the underlying substrate and probably do continue to remain symptomatic. And using very sensitive myocardial imaging of late, patients, it has been reported that patients continue to have subtle myocardial contractile abnormalities too, even when the ejection fraction has recovered. So there's probably a chronic component to this condition that we're beginning to recognize. Just data from the larger INTERTAC registry, again showing that the long-term outcomes, and here the comparison is between Takotsubo and acute coronary syndromes, and they showed that the outcomes are very similar between ACS and Takotsubo. But if you divide them by triggers, again, just like we showed at the Mayo Clinic registry, this larger INTERTAC registry also showed that the outcomes are very different depending on whether it's an emotional trigger, who do the best, or a physical trigger or neurological trigger. Those patients seem to do the worst. So remember, the type of trigger determines long-term outcome. So final few slides here. In conclusion, we've covered most of these points already. The condition is very similar to acute myocardial infarction. Remember that 1 in 10 patients are male. 30 to 40% present with acute heart failure, and some people have wondered whether this is actually an acute heart failure presentation rather than an acute myocardial infarction, and we could debate about all that later. Triggers are frequent, and 1 to 2% recurrence rate. So despite 2 decades of work, really, there are some fascinating questions that remain. For example, why is there a female predominance? You could say, well, it's something to do with estrogens. Well, but as I said earlier, if it was just simple as that, then most women would get it, and it's not the case. Why the postmenopausal state? Some people have suggested that estrogen withdrawal leads to increased catecholamine sensitivity. That might be true, but it's certainly not been proven. Why do only a few people get it? We've touched on this. Why the pattern of regional wall motion abnormalities? People have purported that the distribution of beta receptors across the myocardium may determine it, but I didn't show you, but we have, and others have shown case reports where the first presentation, the type of variant is a certain type, and the second presentation, the variant is totally different. So a person can develop inverted Takotsubo one time and apical ballooning another time. So if it was as simple as the receptor distribution, you would think that it would be the same pattern each time, but it isn't. Why is the recurrence so rare, 1 to 2% per year? If we have a patient who's declared themselves as being susceptible to this condition, it seems that this condition doesn't occur at the high frequency as you would think. And what are the optimal therapies? We have no randomized trial data. We need data in this area. So what is the future? This is my final slide, and I'll stop here, Dr. Singh. But I'm glad to say that there are some trials now going on. There are some studies that sort of really focused studies looking at this idea of this long-term ongoing symptoms and LV dysfunction that has been reported and really characterizing that better. There are randomized trials using ramipril and acetylcysteine, an interesting combination. I'm not sure why they chose these. There's a Broken Sweetheart trial that's going to start where they're going to do a 2x2 randomization to drugs that improve microvascular function using adenosine acutely and dipyridamole chronically, and randomizing to apixaban, which again is an interesting choice given the fact that thromboembolism is pretty rare. I'm not sure why these investigators are looking for that. But anyway, the interesting thing and important thing is that people are now designing randomized trials, and I think we will have better understanding of therapies in the years to come. So with that, I'll stop here, Dr. Singh, and thank you very much for your attention.
It was the most fascinating presentation I've heard from you. I've heard you speaking on this, but I think the updated version is I think a feast to not only to me but to people who are attending this webinar. Before I go to many questions that people are eager to ask you, let me ask you a couple. One, I always taught the residents that there is a score based on what you described on the high BNP and a very low troponin. People have described BNP to troponin ratio being very high as a distinguishing feature of Takotsubo versus ACS, routine ACS due to plaque rupture having been more than 2,000 or 800 or something. Has that score been validated, or has that score been developed with the 5th generation troponin assay?
Definitely not done by the 5th generation assays. One of the things about this condition is that it's not as common as acute myocardial infarction, so it takes a long time to collect patient numbers, have a large registry. And so most case series are small, which is why the INTERTAC registry is so important, because this is the largest group of patients and they're developing larger cohorts from it. But most of the studies, and we did one on looking at BNP to troponin ratios, And the series was very small. So there were more hypothesis-generating papers, and even subsequent papers have really been hypothesis-generating. But the fact remains true that ratio of BNP to troponin has always been the same, which is that there is a big difference between that ratio between Takotsubo and myocardial infarct patients, because Takotsubo patients have higher BNP and lower troponin, and that's what gives that ratio to be different.
I think that's what everybody should remember, is that it's because of the extensive myocardial dysfunction, the BNP is so high, the filling pressures, not only they present as systolic dysfunction, but as you said, diastolic dysfunction as well. And so the BNP is out of proportion to the level of troponin. I think that's one take-home message. The second thing I wanted to ask you was, what if patient has concomitant CAD? And you touched upon that. So if I have a patient with ACS, has a 80% LAD, but looks stable plaque, it doesn't look like ACS, how do you then go about managing this patient? Do you say patient has Takotsubo, or do you do follow-up? How do you tease out whether this is ACS versus Takotsubo?
Fortunately, that dilemma is not very common. We looked at that in our series of over 100 patients, and what we found was 10% had obstructive disease, but it was mostly in branch vessels. And if you had Takotsubo, typically that has to be the LAD or a large vessel, right, or multi-vessel high-grade lesions. We just didn't see that. There have been larger cohorts. Again, the Intertac group have published this, where they reported almost 20% of patients had obstructive disease. But generally, again, it tends to be branch vessel. It isn't as extensive. That said, there is the rare patient, the one you're talking about, who has a high-grade lesion, but has regionals that are typical. I, again, underscore rare. In these patients, I think you just have to hedge your bets and say, like, this. If it looks very classical, you could just argue that the two have coincided. But I'd be very careful. I feel like a lot of those times it's that LAD lesion.
Hedge on the side of treating rather than just waiting. This is Takotsubo. I would treat LAD.
Correct.
Even it may be a type 3 LAD, it's wraparound, and maybe the LV dysfunction is as a consequence of plaque rupture that is not angiographically evident.
Exactly. You could do MRI, but, you'll never get away from this dilemma, because you could have brief stunning and no infarct from the LAD lesion. And so nothing will get you off this, and ultimately your clinical judgment is what really matters.
Let me ask you one more thing before I go to the questions. So have you or your group looked at artificial intelligence of anything, ACG, echo, or what have you, in making a confirmatory diagnosis for Takotsubo?
We haven't yet. The Intertac registry is looking at that using machine learning and artificial intelligence to see, again, using ECGs and biomarkers. So I think there will be some information, but I can tell you for sure that nothing that AI, as good as AI, will be, largely because the data set's going to be very small.
Yeah.
I think that's where the challenge will come.
Okay, let me go to the questions. I think there's so many of them. I want to pay due diligence to each person who's attending it. And thank you, everyone, for attending. It's been an overwhelming response. So let me go to the first one, which says, are there any imaging or risk factor predictors for recurrence of Takotsubo?
Fascinating question. Actually, I hadn't thought of that. I would have to say that I'm not aware of any. The things that we have, as I mentioned earlier, are clinical characteristics like the history of anxiety, depression, emotional triggers. These are the patients who seem to have recurrences, but no imaging finding that I'm aware of.
Okay, so stay tuned till Dr. Prasad whips out another paper on predictors of recurrence of Takotsubo. Thank you for that question. So second question is, any proof for using carvedilol?
Yeah, so again, like I said, there are no randomized trials. I think this is an important question because carvedilol or labetalol that has more sort of alpha-beta component to it is possibly better because it provides more complete blockage or inhibition of the catecholamine system. So in those ways, we do encourage the use of carvedilol or labetalol over other beta blockers, but the reality is most people end up on the most common beta blocker that's used, which is metoprolol.
Yeah. Okay, how about the question, that is also a very good question. So if you call it stress cardiomyopathy, how about if people have not had any stress? Why do they have Takotsubo?
Yeah. A really important question. That should be on that slide of mine. That one's on. So this is my hunch, and I'll tell you what it is.
Yeah.
And I do actually resort to asking patients questions, sometimes to the point that I feel like I'm delving too much into their background. But my hunch is that a lot of people have repressed stress or unrecognized stress. You know, it's really interesting. You talk to people, the first time they'll say, no, I have no stress. And then you ask, are you sure, or what happened last week? And suddenly they'll say, oh, yes, you know, this happened and that happened. So I think, number one, people either don't recognize they're under stress or don't want it to admit, or chronic low-level stress or medium-level chronic stress, I think, is also in many of these patients.
Maybe it's a wonderful idea just to administer some kind of validated questionnaire that for anxiety or depression to everyone who presents with Takotsubo, to bring out these very facts that maybe the 1/3 thing that you were talking about, having no emotional physical trigger, maybe it's underestimated. Maybe there are more people who will come out with that, right?
I think that's a great idea.
Okay.
I would add to you, Mandeep, I didn't show you the data. So when we were thinking about this a lot, we did personality scores. We thought that maybe there'd be certain personalities, and it didn't pan out. We didn't find any particular personality that was more prone to it. But those are the sort of things that I think we need to look more into.
Sure. How about, are there any possibility there are other environmental triggers like toxins or anything environmental, do you think?
We haven't come across toxins, but of course, as you will be familiar, you know, environmental triggers, of course, play a huge role. We talked about COVID-19 pandemic, earthquakes, world sporting events like World Cup soccer have all been associated with bumps and incidents of Takotsubo, but certainly not toxins that I'm aware of.
How about SGLT2? Do you prescribe or no data?
No data on SGLT2s. You know, I think it'd be hard to prescribe something that we think is largely reversible and start giving sort of these novel agents too. But yeah, I mean, who knows? At the end of the day, the drug we want to discover is a drug that can reverse stunning, right? Because that you would speed up recovery.
Yeah.
So that's really what we want to find in the drug to treat it.
Yeah. Now, the other question they have is this is an observation one MD has, David Kotalba. He mentions that he lost a few patients in the early postmenopausal period. And he thinks that the cardiogenic shock, the mortality prognosis is worse in those kind of youngish postmenopausal.
Yeah, I think that's a good observation. And I think it's because these patients present with a much greater stress as they're initiating a thing. And you see the same in men. So men do much worse. And in my experience, the reason for that is that the trauma that leads to the Takotsubo in those patients is much, much greater, and so they do much worse. And that's true for the young women too.
Yeah. I would add to that the happy heart you mentioned is more common in males. I was reading about it, and then the mid-ventricular variant is more common in them. And the prognosis, you say, is not as good as female. Right,
yeah,
right.
Exactly.
The next one is, do people who have recurrence of Takotsubo have a better prognosis?
I don't know is the answer to that. Because remember, again, small number of patients, and then only 2% of them get it. So most of the papers on recurrences are a very small number of patients. So it certainly doesn't seem to highlight a group that have worse prognosis, because you might think that if people are getting recurrences, they're going to do worse. But I have had patients with 4, 5, 6, 7 recurrences, and they all are still surviving them, It becomes life-limiting for them. They end up in ERs, hospitals, and that small subgroup of patients with 6, 7 recurrences is a real challenge to manage, because their life becomes miserable.
Maybe the prognosis is determined by their presentation. So for example, old lady who's in ICU with septic shock, and now is also found to have Takotsubo.
Yes. So the physical trigger.
She's not going to do well.
Correct.
Right?
Yeah. I think that's a really important point because I think people who have agendas sometimes like to say, well, Takotsubo is this terrible illness, so we need more research on it, and so on, which we do. But again, this is the point that really the mortality seems largely to be related to the concomitant physical triggers, the severe illness, ICU situation. But it is true that the cardiomyopathy per se rarely can lead to terrible outcomes.
Now, you mentioned that angiogram is needed for confirmation, which I agree, and that is determined by, because Takotsubo affects not just one coronary segment, but more than that. So the degree and extent of LV dysfunction is out of proportion to the presumed CAD involvement. Now, in older ladies, patients in ICU, or even on the floor, do you think after you make a diagnosis of Takotsubo by echo or non-invasive, do you have to then send everybody to a cath lab for an angiogram to make a diagnosis?
I think if you want to be sure, right? So some people will say, well, it looks like Takotsubo, it must be, right? Well, I think if you don't want to miss a high-grade LAD lesion, then I think you must send them to, and I always tell you from our own experience, we've had cases where the echo has been reported classic of Takotsubo, you take them to a cath lab, they have a tight LAD. So I think, or multivessel disease, right? So I would say that yes, it's mandated.
Before you subject the patient to this diagnosis and pray for recovery in 4 to 8 weeks, a patient not make it because he or she has a LAD and a multivessel disease for which you need a treatment. Right. So whenever possible, we have to do
coronary imaging. The patients where we don't end up doing are the ones who are on bone marrow transplant units, oncology units, major trauma, very extreme elderly, hip fractures. I think we have to accept that you just can't do it. But I think it's reasonable to call it probable Takotsubo. Just hedge your bet a little bit.
Absolutely. Okay. I think somebody asked 3 episodes of stress cardiomyopathy. You said 7, so you trump that. Then the second one they have is the one missed the LVOT slide. Can you repeat that for them?
Yeah, absolutely.
What happens if there is a LVOT obstruction to these patients?
Yeah, so remember that this typically occurs in the apical ballooning variant. So because the base is hyperdynamic, you get essentially a HCM type of physiology where you're getting obstruction to blood flow out of the LVOT because the base is hyperdynamic. So in other words, you will see hypotension, but the hypotension is not due to pump failure predominantly, but because of this LVOT obstruction. So when you have LVOT obstruction, the management of that hypotension is very different. Yeah. You need to give them negatively inotropic agents, beta blockers reduce the contractility of the base, sort of somewhat counterintuitively, and phenylephrine occasionally just to cause peripheral vasoconstriction and relieve that outflow tract obstruction. So the key thing about that point is that if you have a hypotensive patient with Takotsubo, get an echo, look for an outflow tract gradient. That's the most important learning point there.
Yeah.
Many a times they will recover spontaneously without you doing too much to them anyway, as they relax and recover. And so it's mostly not to do harm by giving them inotropes and so on to maintain their blood pressure.
It reminds me of this when we used to do the cardiology fellowship, suicidal right ventricle in patients who get their pulmonary stenosis relieved because of infundibular stenosis. Same concept. You fill up the tank, the right ventricle or left ventricle in this case. You give beta blockers and not beta agonists, and you give phenylephrine to support. Very nice. Postmortem studies?
I'm not aware of many, actually. There are biopsy studies of a few patients in the early days, and there haven't been many repeated. That's where you get these sort of contraction band necrosis seen, just like you do in other situations where there's been catecholamine toxicity, but not postmortem studies. And remember, postmortem studies will be very difficult because there really isn't any significant damage to the ventricle. So I'm not aware. I mean, there may have been a case report here or there, but I am not aware of any significant studies done on it.
The beta receptor density and pattern of involvement of ventricle you nicely touched upon, and that was for a while and still may be in the running in terms of pathogenesis for distribution of how this apical variant, which is the commonest variant, has come around, but you nicely highlighted that that is not the case because these patients present differently in subsequent episodes of Takotsubo. So that's not the whole story. And so there are a lot of things that we need to learn still from this disease, which remains to me an enigma, but fortunately the prognosis is good, the recovery is spontaneous. Let me go to the next one. How about differentiating the Takotsubo from myocarditis when the trigger, for example, is an infection in ICU?
I think CMR, cardiac MRI, is very helpful because at the end of the day, that is our gold standard, right? And if the MRI doesn't show changes of myocarditis, then I think you're safe to say that you've excluded it.
So it's more edema
Yes.
in Takotsubo, and it's more patchy epicardial pattern in
myocarditis.
LGE, in myocarditis.
Exactly. Those are the differentiated.
Yeah.
And the edema is very frequently present if the right imaging runs are done. I'm not an MRI person, but that's what I understand. So I think that's frequently present. And you should not see any gadolinium sort of enhancement early runs or in late gadolinium imaging.
That is a very important point, though, right? I mean, if you have a subendocardial, you say it's ischemic. You have subepicardial, late gadolinium enhancement, you say it's myocarditis.
Right.
But in this case, there's a paucity of enhancement
Exactly.
in favor of edema in the myocardium, which is hallmark in the
So
right
that's why I
setting.
say that use cardiac MRI as your tool whenever you have doubt, because that will get you out of the sort of dilemma that you have for making the diagnosis.
Yeah. Okay. All right. The next question is, in recovery, do patients recover from depression also, as well as their LV function?
Well, maybe, the point I was making about the depression, this is sort of anxiety depression we're talking about, right?
Yeah.
Is that
I think
question?
that is what
If that's the question, really, it isn't that they have acute depression. It is that they have a chronic history of anxiety depression. And so, that's going to continue subsequently too, which is why I think as part of the management strategy has to be eluding. And I like your idea. I don't think it's commonly done, but using a scoring system to screen for anxiety depression in these patients.
And treat the root cause rather than the consequence, which can be Takotsubo, right?
At least anecdotally, in my experience, the
Yeah.
patients who've had multiple recurrences, they have a high burden of anxiety depression.
Very nice. Very nice. Okay. The next one, again, is air pollution, automobiles, no data,
No
right?
data.
No data. What are the most significant unanswered questions that you have about Takotsubo in terms of clinical as well as pathophysiological mechanism?
Yeah, so
We had the last slide,
we
but
alluded
yeah.
to that, but I think
Yeah.
that's such an important thing. It's worth repeating. So in terms of pathophysiology, I think we need to understand why only a few patients get it, and so what is that substrate, so that's the one piece. Who are these patients, and better characterize them, and really, I think there's many R01 grants to be written here, really, to spend a lot of time, really carefully characterizing these patients. And people have done it in small numbers, but it needs to be done very carefully. That's number one. The other thing is, what is the mediator of the stunning? Because if we can understand the cell signaling of the stunning, I think that will give us so many answers about
Excellent.
hibernation, stunning, and also develop therapies to treat that. So I think those are the biggest questions in the pathophysiology side of things.
Yeah.
In terms of therapies, I think clinical trials, and they're beginning to happen now.
Pete Ferranta, I think from La Crosse, has a question about depression and anxiety. So how many patients are actually on these medications, such as SSRIs, at the time of presentation, or have these type of meds been looked at in regards to preventing a recurrence? I think you touched upon that a little bit.
I mean, not in a randomized trial, but certainly we have, anecdotally tried them and with variable benefit in terms of preventing recurrences. A large number of these patients are on these agents when they present, because in our Olmsted County data, almost, if I remember correctly, 60 to 70% of patients had anxiety or depression for years before it sort of preceded the
So I think we have to pointedly ask these patients about these
Yes,
because
absolutely.
they're so common.
Yeah.
How about when the LV function recovers, do you take these patients off beta blockers and ACE?
I typically do, unless there's another
So how long
indication.
do you give it? 2 months?
Yeah, usually around 1 to 2 months. Most people recover within the 1 month, so I treat them for about 2 to 3. Make sure that you give them a good period. Remember that we're now beginning to find the subtle abnormalities remain, right? So I think a little longer period of recovery and treatment is okay. And then I would stop it because there's absolutely no reason to continue them. There's no data to suggest it prevents any.
So last couple of questions in 30 seconds. So what I could see is in a series of 20 patients in the classic form was that the exacerbated movement of the base generated a falsely normal diastolic function, or what is your experience?
Diastolic function?
I think diastolic dysfunction is the dominant along with the systolic dysfunction, right?
It's I would say it's the under-recognized feature.
Yeah.
And I think when patients do poorly, it's because it's a combination of bad systolic and diastolic dysfunction.
Last question about role of myocardial contrast echo to differentiate the Takotsubo from true myocardial scar, who are not good candidates for angio.
I think it's fine. If you have very good echo imaging and you have slim patients, then absolutely you can differentiate. But the challenge is getting good
But I
imaging.
think cardiac MRI,
Exactly.
that's wonderful.
When you have cardiac
right?
MRI, why would you want to take chances?
Don't do stress echo, just do cardiac MRI.
Yeah, or myocardial echo perfusion imaging, which have been reported to show differences. You see impaired microvascular perfusion with perfusion imaging with echo, but the image quality is nowhere near like cardiac MRI.
Yeah. Okay. All right. Thanks, Abhi. It was a fascinating hour with
Thank you,
you,
Lee.
and hope to see you again here.
It was a pleasure.
Have a good night, everyone.